getting ready to start our preventative measures, and I have Dr. Ogbureke in with us. I'm just so excited that he is here. He is a professor of oral and maxillofacial head and neck pathology and former chair of the Department of Diagnostic and Biomedical Sciences at the University of Texas Health Science Center in Houston. He earned his dental degree from the University of Ibadan and master's degree in oral pathology from the University of Glasgow and a Doctor of Medical Science degree from Harvard University. He also holds a law degree from Suffolk University in Boston and is licensed to practice law in 3 United States jurisdictions. He is a trained specialist in oral and maxillofacial surgery as well as in oral and maxillofacial pathology. And he is also board certified in oral and maxillofacial pathology. His clinical practice is concentrated in the area of diseases that manifest in the mouth. As a molecular biologist, his laboratory studies the role of the sibling family of proteins in the development and progression of oral cancer. His lab has published numerous papers on the biology of oral cancer. He is a 2-time full-time Fulbright Scholar, 2010, 2018, and a recipient of numerous national and international awards, including the 2016 King James IV Professorship of the Royal College of Surgeons of Edinburgh and the Certificate of Congressional Recognition, U.S. House of Representatives 2018. Please welcome to Friday Night Live, Dr. Ogbureke. Yes, sir. Hi, how you doing, doctor?
Thank you very much. I'm doing so well. Thank you, Catherine, for inviting me to the show. I truly appreciate the invitation, and I look forward to a very, very productive discussion.
Yes,
how
sir.
are you doing today?
I'm doing outstanding now that you're here. It is just an honor to have you on the show. And, you know, I did my thesis a little bit on salivary gland cancer. So this is really dear to my heart, the oral cancers or the cancer of the mouth for the audience, so that they understand what we're talking about. So I wanted to start off, if it was okay, to tell them a little bit what a maxillofacial pathologist or doctor is, because I'm not sure if the viewers know exactly what that specialty does.
Well, again, thank you, Catherine. Thank you for having me. The oral and maxillofacial pathologist is a doctor that deciphers, that is, look at the oral cavity, the mouth, and diagnose diseases that present in the mouth. And some of these diseases may not actually originate in the mouth. There may be diseases that are elsewhere in the mouth, the guts, name it. But they are manifesting in the mouth. So the oral and maxillofacial pathologist is able to see these lesions sometimes before even the physician, the general doctor, knows about the existence of these diseases elsewhere. So they may serve as the mouth serves as the window. It may be the very first indication of something happening elsewhere in the body. And the oral and maxillofacial pathologist, with a background in dentistry, of course, serves as the first, person who may be able to see these things and identify them and diagnose them. And beyond that, as pathologists proper, we are able to look at tissues, biopsies that are obtained from these lesions, these disease conditions in the mouth. We look at them under the microscope, and we are able to say precisely what type of disease it is. The sample that is taken, of course, is what we call the biopsy sample. The biopsy specimen, this is sent to us, and then the oral pathologist will, after processing these tissues, will look at them under the microscope and then be able to come up with a specific diagnosis. This is particularly more pertinent in instances of cancer. That's what, which is of course the subject of our discussion today. So we are able, for example, to diagnose specifically oral cancers in the mouth by through these biopsies.
Okay. So let's go ahead and start talking about oral cancer. So what is oral cancer in like its simplest terms where they could understand?
Well, oral cancers are those cancers that occur within the mouth and the throat area, inside the mouth and the throat area. Essentially, that's what they are. In technical terms, we recognize that over 90% of these cancers would be ones we classify, we designate as oral squamous cell carcinoma.
Mm-hmm.
And they arise from just the covering, in technical terms called the mucosa, the covering of the mouth, the various soft tissue covering of the mouth. And then the other 10% or so will arise from minor glands that secrete saliva in the mouth, called the salivary glands. So those would be salivary cancers. But dominantly, most of these cancers that occur within the mouth would be those designated as oral squamous cell carcinoma. And in fact, because of that, for the most part, the term may be used interchangeably. We may just call them oral cancers.
Okay.
And so when people make reference to oral cancer, they are referring or they have in mind these major groups, these 90% that are truly, again, when the pathologist looks at them, would come up with a diagnosis of oral squamous cell carcinoma. Each of us would know that our mouth is covered by this soft tissue we call the mucosa,
Mm-hmm.
all through, the gums, the tongue, the cheek, inside the cheek, the upper jaw, the palate area, we call it. They are covered by these mucosa. So oral cancer can arise from any of these sites. There are, however, sites that are much more prone to cancer, oral cancer, than others. For example, the tongue. And even on the tongue, the area of the tongue that is much more prone to cancer would be the sides of the tongue. We call them the lateral tongue, and the underside of the tongue, or the ventral tongue. That is the underside of the tongue, as well as the floor of the mouth, the gums. We do also have significant number of them arising from the cheek, the palate, that is the roof of the mouth towards the back area we call the soft palate. And a good number of these arise beyond the soft palate towards the throat area, the oropharyngeal cancers, we refer to them. And again, as I've already indicated, all these areas are dotted by numerous minor glands that are responsible for making saliva and secreting them. And they may also arise from these glands as saliva or salivary gland cancers.
What are the causes of oral cancer?
Very good question. For a long time, we've recognized two main culprits, pretty much identify them as the worst offenders, and that is tobacco use in all its form. It used to be that cigarette smoking was top on that list, but we are beginning to realize that indeed all forms of tobacco use produce the same carcinogens, we call it, that is the same chemicals that will result in, that will trigger oral cancer formation. And then alcohol use, long-term alcohol use, also these have been established as causes of cancer, oral cancers. But again, in recent years, meaning perhaps in the past 2 decades, it has been definitively also established that a group of viruses called the human papilloma viruses are also able to cause a particular group, a subgroup of oral cancers that also behave differently clinically. They cause oral cancer as well, the causation of oral cancer. So you have the three main culprits: tobacco coming first, alcohol, and then now HPV or human papillomavirus. And then there are some other factors also that are probably more contributory when these other three biggies, I call them, when one of these three biggies is already present.
As a patient, is it easy to recognize, or do you see any signs in the mouth, or do you notice anything that may um, say, "Well, I probably need to go to the dentist to check this out"? I mean,
Yes, absolutely. Yes. That's an excellent question. That's really the key here. Incidentally, that's the paradox. Oral cancers um, should be easy to identify.
okay.
They should be easy to identify. And think about it. The oral cavity is so available. It's so amenable for examination, including self-examination, to note things that were not there yesterday or 2 days ago that are beginning to be there on a permanent basis. And of course, certainly with your dentist. The dentist should be able to look carefully, regularly, intrusively inside the oral cavity to see early signs. And the early signs of oral cancer are not so subtle. Most of the time, you will recognize them as, again, as I just said a while ago, as abnormalities that were not there 2, 3 days ago or
Mm-hmm.
2, 3 weeks ago, but are beginning to show up and remaining there. And we call these oral premalignant lesions. That's the technical term. But in common parlance, those will be precancers. That is, they are changes that are preceding the actual progression to cancer. And that's the good news. If diagnosis of these precancers are made, it means that they can be treated before, again, the emphasis is on before they become cancer. So that is the preventative approach. Oral cancers are actually preventable largely. Unfortunately, we are still slow at taking advantage of this reality that if we spend more time at diagnosing the early forms of it, then we will be able to avoid the transition to full cancer that presents with more challenges in terms of patient management. So yes, then the individual can carry out self-examination with a mirror in front of you, look under the tongue, look by the side of the tongue, check the gums. If there are any changes, whitish changes that are permanent, they are not going away, you can't rub them off, then those need to have the attention of the dentist, who can now biopsy them. You see,
Okay.
now take a piece of those lesions and then send them to us, the pathologists, to make a determination as to what stage those lesions are, if they are precancers. And if they are, then at that stage, they are usually very small. So the dentist can go in and remove everything and avoid the development of cancer at all.
I didn't get a chance to ask you, are most of the oral cancers benign or malignant, or is there one that's more dangerous than the other?
Very good question. Generally, just because they are cancers, just because we call them cancers, they share the characteristic of being malignant. They are, they are dangerous. They are bad guys.
Okay.
Yeah. But again, we stage them. They are different. The precancers I've described, again, I keep coming back to those, are not yet cancers.
Okay.
They have those signs. But the good news is that until they break that threshold of becoming cancers, they are not yet cancers. So if you read complete readings of them at that stage would cure the patient more or less. But the actual cancer also has stages, to your question.
Okay.
Yes, depending on when the diagnosis is made. If they are made early enough, there may be a stage 1 or a stage 2 oral cancer. They will still be treated as cancer, but those patients with early stage diseases have a better chance of survival. In other words, they may not have recurrence as compared with patients with later stage diseases, stage 3, stage 4. Stage 4 obviously is the other end of the spectrum, of bad news. And most of the stage 4 patients actually will die from the disease eventually.
Yes. Okay. What about current treatments that are available for someone that has oral cancer diagnosis?
Unfortunately, for real cancer, that is full-blown cancers. We call them invasive cancers, which, of course, is just a repetition. Cancers, by their very nature, are invasive. Uh, Full-blown cancers of the mouth are still largely treated by surgery. And of course, these are extensive surgeries. You can imagine if it's a cancer of the tongue, that may necessitate removing half of the tongue, for example. So they are extremely debilitating in terms of the surgical approach. But this has been the mainstay of treatment for a long time, as we know it. And in spite of that, the recurrence rate and the survival is still very low. About 50% of these patients treated surgically, sometimes with radiotherapy as well,
Mhm.
will come back with recurrence. They will have recurrent disease. And half of those patients coming back with recurrent disease will die from the disease. So the challenge we have now, and that's part of what my lab has been interested in for a long time now, is to come up with chemos, as we call them, that is drugs rather than surgery, that actually fight the cancer cells
Mhm.
without subjecting the patient to extensive surgery. Or alternatively, a combination of those chemos that limit the extent of the surgery that is carried out so that patients do not end up with extremely disfiguring results as a result of extensive surgical approach. So efforts are going on now. Chemotherapy, immunotherapy is actually on the forefront of the research now to come up with immunotherapies that instruct the body itself, the body's immune system, to fight drugs that will instruct the body immune system to fight back oral cancers and limit the extent, or in some instances, completely eliminate the choice of, as the only choice, surgery as the only choice of treatment.
Okay. Um, so we talked about the survival rate, and I know you said if it gets up to stage 4, the chances of survival is really not good. But if we can catch the cancer at its early stages, in stage 1 and stage 2, we have a better chance of possibly taking care of it. Am I
Yes,
correct? Okay.
that is correct. In fact, indeed, 80% of patients, even with stage 1 cancer, have, there is 80% would have a 5-year survival rate. That is at least from the time they are treated. We don't use the word guarantee, but they are not likely to die from the cancer 5 years from that point. And that number comes down precipitously so low once you get from stage 2, stage 1, 2 to stage 3. And of course, for precancers, it's almost, if they are detected on time and completely gotten rid of, the chances of developing oral cancer is even much more reduced, far significantly reduced.
Are there some preventative suggestions that you can give us, or things that we can do, maybe with lifestyle, or anything that we can do to possibly protect ourselves or reduce the risk of getting oral cancer?
Yes, of course. The common sense ones are first start with the most preventative measure we can institute ourselves as individuals,
Yes.
not requiring the doctor to help us do that. And that is self-consciousness of our mouth, self-examination, not when there is an abnormality within the oral cavity. Have regular dental check. Remind your dentist if they don't see. If you're not sure they're doing it, say, please, I would also like you to look around and make sure I don't have any funny lesions that may lead to cancer, and just chuckle. They will understand what you mean and carry out those checks and at least let you know. Do that every 6 months. That will be my recommendation. Secondly, the etiologic agents, as we call it, or the causes, the non-causes like tobacco use and alcohol use, those have been established. Or, so if an individual can cut down or at least eliminate completely those lifestyles, social lifestyles, and adjust to them, that would be good. And in younger patients, HPV vaccination.
Okay.
And now it is for both male and female young patients. This will certainly protect them from developing the HPV-related type of oral cancer, early vaccination. And this brings me to an important point too. You may not have any of those. You may not be a tobacco user. You may not be an alcohol user and all that. And we have seen this increasingly in the past few years, particularly in younger patients, developing cancers that are often known. We can't trace it to anything. The patient comes in and says, but I've never smoked. I've never had, taken alcohol. How could I get this? Why me? And we are still, some of those happen. We later on realize that some of those, with the advent of HPV, we began to realize that some of those are in that cohort, that group that is HPV instigated. But others are still, we still don't know. We are still, this is an area of intense inquiry as we speak. And that again goes to reemphasize the need for prevention, early detection. An individual should be able to see an abnormality or a change in the oral mucosa inside the mouth and alert their dentists to check it out.
Okay. I was going to ask you one more question, and I think you kind of answered it a little bit. You tapped on a little bit. I was just curious. Can this be a hereditary type of disease? And then also, have you seen in your research particular age groups that are more prevalent to having this?
Very good question. Let's start with the age group thing. Okay. It used to be that oral cancer was regarded, unlike most cancers, as a disease of the elderly, meaning individuals 50 and above. But that, just like cancers of other regions, most, not all, but that is changing. That has changed in the past 3 decades or so. As I just indicated to you, we're beginning to see cancers that we cannot really explain in much younger patients. And I'm talking about patients in their 30s and 40s. Yes. So, but regardless, largely it still remains a disease of the elderly. It is still dominantly, people in their 50s, 60s and above. And the risk increases with increasing age, for sure. And also it used to be that, demographically male more than female. But again, that gap is closing. It's almost 1-to-1, 1-to-1 right now as we speak. Male are still slightly more prone to oral cancer than male. And what is clear with respect to the demographics is that blacks are far more affected with oral cancer. They tend to develop oral cancers more than their Caucasian counterparts. So that is, those are things we know. clearly. And epidemiologically, it's still a disease. Oral cancer is still far more in the Asian continent, India, and so on. In fact, it is the primary cancer in India. It is the number one cancer in India. And of course, this has been attributed to the use, tobacco use in various forms and so on, which is very prevalent in those cultures than we have them here in the Western world and other parts of the country. And generally speaking, in developing countries, the rate of oral cancer is much higher than we find them in developed countries like the United States and other Western countries.
Well, Dr. Ogbureke, that's all I have. I mean, I think we kind of covered pretty much everything as far as for the viewers to kind of get a better understanding of oral cancer, what it is, what to look for, when to go to the dentist, preventative measures, causes. We pretty much covered all of it. Did you have any final remarks before we end the discussion?
Well, thank you again, Catherine.
Yes, sir.
With respect to oral cancers, I will just repeat, and indeed any other cancer for that matter. Let's note the salient aspects. It is preventable. It could be diagnosed early and the consequences can be stopped. Its progression can be stopped if we are able to identify these preceding lesions, these pre-cancer lesions, and take care of them, which is usually much easier, take care of them early enough. And the secret is self-examination, talk to your dentist. And if there is any suspicious lesion, they should be biopsied. They should immediately take a small sample of those lesions and send them to a pathologist. And often we advise that those samples be sent to an oral pathologist who is actually specialized, who has experience in the diagnosis of cancers of the mouth. Those would be preferred to sending them, just generally to pathologists who may not have as much experience with the oral cavity diseases. So those are the main things for young patients who are still within that ballpark, teenagers, early adolescent. They should consider, male and female should consider HPV vaccination. Those are now available. I believe that those are the key. Again, prevention, prevention, prevention. Sure. Early detection, early detection, early detection.
Yes, sir. Well, thank you so much, Dr. Ogbureke. I just want to say thank you. It's really an honor to have you on the show. Thank you for volunteering and giving up your time. I know that you're very busy, and best wishes on your future endeavors, best wishes on your future research, and hopefully we can collaborate and do something later on in the future.
Sure, I look forward to that. Thank you, Catherine.